Well, it's 6 o'clock. My name is Dr. Oscar Knoll. I'm one of our orthopedic centers, or surgeons here at the Center for Spine and Orthopedics. Want to welcome everyone tonight to our fifth actual virtual CME lecture on behalf of all of our physicians and staff at Center for Spine and Orthopedics. We have done a lot of these lectures, if you guys have been on for some of them, over various spine, orthopedic, and pain management topics. I really want to thank Health Images for co-sponsoring these lecture series and for inviting Dr. Sana here tonight, one of their radiologists, to join us and answer your questions at the end of this lecture. Tonight is kind of an interesting topic. It's something that maybe not everybody knows about, but it's pretty important. And in the diabetic patients, they can have a lot of issues, and diabetic Charcot neuropathy is one that Dr. Kuhlman, our foot and ankle specialist, is going to talk about tonight. So Dr. Kuhlman is a board certified podiatrist. He's fellowship trained in foot and ankle surgery. He's also level 1 certified in workers' comp. He does foot and ankle reconstructive surgery, arthroscopy, trauma, sports medicine of the foot and ankle, plantar fasciitis. He does Lapiplasty, which is like a 3D bunion correction. He also does diabetic wound care, runs a wound care center, and does diabetic Charcot reconstructions. And he was recently at a course, and I think he was named one of the top 10 in the country for this. So he is currently the medical director over at the Wound Care Center, like I said, at North Suburban Medical Center. He joined Center for Spine and Orthopedics in April of 2017 after completing an advanced reconstructive surgical fellowship at the Professional Education Research Institute in Roanoke, Virginia. During that time, he completed almost 2,000 complex procedures in a coal mining community, so high volume foot and ankle stuff, caring for many patients who'd never even seen a physician before. So you can imagine working down the mines and boots and all the kind of stuff that he had to have seen. So he's excellent. Dr. Kuhlman sees each patient kind of as a unique set of foot and ankle conditions because everyone's different. He takes great pleasure in listening to individuals and formulating his best treatment to suit their needs and concerns. You can really get an idea of how much he cares about his patients just by reading some of his online reviews. And while I don't necessarily agree with this fact, I think that he may be the only physician in our practice to receive all 5-star reviews. So he is definitely well thought of. On a personal note, he grew up in Toledo, Ohio. He spends much of his free time with his wife, Raquel, and their 2 dogs, Atari and Pong. He spends his spare time hiking, like 14,000 foot peaks, skiing, snowboarding, and attempting to play golf. So prior to Dr. Kuhlman's lecture, I'd like to introduce also Dr. Kevin Downs. He will lead tonight's wine and beer tastings. Dr. Downs is a retired OBGYN physician who specializes in infertility medicine. He's been a sommelier for more than 5 years and is at the event planner at Wyatt's Wet Goods in Longmont. Kevin became interested in wine during his years as a physician. And so please welcome Kevin Downs. And he's going to talk to us a little bit about our wine and beer tonight.
Thank you very much. We'll start with the beer. I actually was kind of drawn to these beers when I saw I was in the receiving area when they brought the beers in and saw the Czech lager, and that's the one that's shirtless Putin catching rays. Thought it was hysterical. The beer guys are just getting crazy with their beers, but then I tried it and it turned out it's become one of my favorite beers. So I tried the other beers from this particular brewery, which is Call to Arms. They're down in North Denver, and they have some amazing beers. So I have 4 of their beers tonight. We'll start with the Oktoberfest. I wanted to do an Oktoberfest, and these folks have turned out to make one of the best. They actually call theirs a Seshtoberfest is the name of the beer. And the reason is that it's actually a session Oktoberfest. And what that basically means, it's a little lighter in alcohol than the usual beers, about 4%. So it's an easy drinking Marzen style beer. You hear the term with Oktoberfest, you hear the word Marzen used quite frequently. And that's actually, Marz is German for March, because these beers are actually brewed in Germany. They're brewed in March, and they're aged and lagered over the summer, and they're brought out for Oktoberfest. This is a great example, easy drinking, nice lager, really fun to do. The next one is their their flagship lager called Ballroom Beer. It's a 4.8% real mellow lager, easy drinking, real good summertime beer. I enjoyed a great deal. Then we come to Shirtless Putin, Catch and Raise. This is their dark Czech lager. And Czech lagers are probably some of the best beers in the world. Pilsner Urquell has been voted best world Pilsner probably 1 million times. And this is just a beautiful beer. It's about 5.5% alcohol. They basically use hops that originated in Bohemia. They're called Saz hops. And they make it just this bright, beautiful beer with a very rich, thick, foamy head. Just a delightful beer. And for a dark beer, it's amazingly light and easy to drink. It's really become one of my favorite beers. And last but not least, we have what started to be a drive-by shooting, but they've then renamed it to a run-by shooting. And now at the tap room, it's called a walk-by shooting. So probably soon it'll be a crawl-by shooting. This is a West Coast style IPA. West Coast IPAs are basically they are hop heavy. So it's a fairly bitter beer, but it's, again, has this beautiful kiss of grapefruit in it, and it just calms those hops down really well. And it's just a really easy drinking IPA. About 6.7% alcohol, so be careful because it's a little too easy to drink. But I think everybody will enjoy it if they haven't tried it already. So that's our beers for the night. When I decided on wines, I wanted to do something a little different. So we've done reds, we've done whites, haven't done a rosé yet, but we might as well do another color. So I decided we'd do orange wines tonight. Orange wines are actually becoming a bit of the rage. We had about 3 in our store, and now I think we have about 23 because everybody's just clamoring for them. Orange wines actually started in Slovenia, and this particular one that I have is from Slovenia. It's from the Goriška Broha region of Slovenia, where these wines are particularly well made. It's a blend of 3 whites grapes. It's Ribula, Malvasia, and Sauvignon Nas. And what makes this wine different is the maceration. Usually white wines, your typical Pinot Grigio, Sauv Blanc, Chardonnays, etc., the maceration lasts anywhere from 6 to 10, maybe 12 days at the most. Maceration simply means the wine is fermented with the skins intact, the skins, the stems, so you get the flavor, a little bit of flavor from the skins. But with white wines, they don't like to macerate them for a long time. Well, however, these guys have sort of written new rules. And this particular wine, the Malvasia and the Sauvignon Nas, are both macerated for about a month. And the Ribula, which is about 40% of the mix, is actually macerated in oak barrels for 10 months. So the resulting wine is this bright orange color that tends to actually have some tannins to it, but they're very soft tannins. You get this wonderful flavor. You tend to get some tropical fruit in there, maybe some mango, some stone fruit, such like maybe apricot. On the finish, it's nice and long, a little bit of tannin, a little bit of bitterness, but it's a very pleasant bitterness, and a little bit of almond in the background. Phenomenal wines. These are just great with food, great without food. And I'm seeing why they become all the rage. And particularly the rage now of my girlfriend, Karen. That's her favorite now. So I guess I'll be bringing it home a lot. So anyway, that concludes our tasting for tonight. I hope you enjoyed it, and I hope you enjoy the wine and the beers. Thanks.
All right. Well, I think it is my turn to go ahead and start this. So thank you, Dr. Knoll, for such a wonderful introduction there. I am the only physician left with 5-star review, in case you were curious. Also, I do
don't
feel
know.
like I learn a ton from Dr. Downs every time he goes through this. So I hope my screen came up. I'm kind of going for the shock and awe here on this first initial slide, but this was actually my big first Charcot reconstruction. And as you can see, this whole foot's pretty much completely open. There's a lot of things going on. And I really had to take a minute and just step back during this case and just realize how cool kind of the surgery techniques and things that we can do are to kind of help some of these people, especially our diabetic patient population. I know Dr. Knoll kind of already introduced me. Oh, sorry, but my basic kind of education was I started out in Chicago. I did my undergrad medical school thing all both there. I did Dr. William M. Scholl College of Podiatric Medicine. I followed that up out in Grand Blanc, which is essentially south of Flint, Michigan, right during the Flint water crisis. And this is kind of where I really developed my love of just both Charcot reconstruction and foot and ankle surgery. I was, obviously specialized in podiatry, so that's all we were doing. But I, got into podiatry thinking it was kind of going to be the bread and butter surgery techniques, but I, started going under all these foot and ankle orthopedists, and they kind of showed me the world of Charcot, total ankle reconstruction, and I fell in love there. So I furthered that up. I went out to fellowship in Roanoke, Virginia, and it was a mining community to a T. We would see patients who had never seen a physician. I mean, we're talking completely medical disasters, and they were walking into our clinic with their foot essentially upside down, and they're like, "Can you fix this?" And I would look at it and be like, "Okay, this is what we're doing today." We did a ton of surgery. I mean, we were in the OR essentially 4 out of the 5 days a week, and doing anywhere between 10 to 15 cases a day. So it was very heavy in the surgical arena. And now I'm currently practicing at the Center for Spine Orthopedics. We have a wonderful group here. We decided to give Dr. Rumley the day off. I know you guys are used to him DJing this thing, but you got me and Dr. Noel instead, just because I think we're just kind of a fun group too. So when we talk about Charcot, this is typically what we see or what we get down the line. So a below-knee amputation on a patient, and this is actually a patient when I was in medical school who I saw, we'll call him WW. And you can see here, he's got a right-sided below-knee amputation. It actually looks pretty good. Incision's well healed. He's got a stump shrinker on, but he had a pretty significant Charcot. And I'm going to go through this case kind of in reverse just to show you kind of what can happen if these things are left untreated. So before his below-knee amputation, the essential look to this patient's wound was this. We had a pretty bad deformity to the ankle there. As you can see, he's essentially walking on the outside of his ankle or on his fibula. And then on the wound on the left-hand side, we're seeing essentially a really big wound over there. I don't know how well it's showing up, but you can actually see some of the bone exposed. And then that kind of red soupy drainage was actually purulence. At this point in time, we're already having that pretty big discussion of, okay, if we can save this, what do we do? Or are we going on to amputation? So we took some x-rays, and the x-rays were pretty, unfortunately, bad. And so when you look at this on WW here, his ankle joint is almost completely destroyed. The tibia there is almost on top of the calcaneus. His talus, which is supposed to be there, is almost shifted completely to the front of his foot. And if you look at the top-down view, what we're seeing is complete fragmentation of the talus and the navicular, as well as some soft tissue emphysema. So that's actually gas infection into the tissue. Now, because it's a teaching institution that we were kind of learning all this from, they kind of did the whole gambit on this guy. So they initially did a quick IND to stabilize his foot, and then they ordered a bone scan and an MRI. Now the bone scan lit up completely. And I know we have one of our radiology experts on here, but this was the entirety of the foot when we saw this. When I was learning, they're like, this is bad, but we're going to order an MRI and kind of see if there's anything worth salvaging. So they went on and ordered the MRI, which showed on this T2 weighted image, essentially all the bones should look black. And unfortunately here you can see almost the entirety of the talus, as well as some of the midfoot bones are showing up white. This can be indicative of infection, but it can also be a stress response. Now with his wound, his x-rays, and his just general presentation, obviously we're leaning more the infectious route, but we did want to go ahead and order a Seratac, or a white labeled blood cell scan. And this showed the uptake essentially in the talus, the fibula, as well as some of the foot bones. So this was all prior to this man's amputation. And essentially, if I would have seen this in my practice with this much infection, I would have been pretty limited as well. But when the patient initially showed up to the office, this was his x-ray, almost perfectly normal. This whole event occurred over 4 months. So it went from this pretty benign, normal looking x-ray to an amputation in less than 4 months. And sadly, when these patients that with diabetes get an amputation, so a major limb amputation, we're talking a below knee amputation or above knee amputation, typically the survivability of these patients is pretty low. And so WW made it to about 4 years, and then he passed away, unfortunately. So the 1 year survival rate, or I'm sorry, the 1 year mortality rate's almost 30% for a below knee amputation. And then the mortality rate for a below knee amputation at 5 years is almost 70%. So he became a statistic, sadly. So just to give you the gravity of this prior to my whole talk, I wanted to give you that case because this is recognition of the deformity itself, and being able to see what's going on is crucial for these patients. And so I know I'm talking to majority primary care world, endocrine world. So I wanted to give you some really basic information, kind of do an introduction about Charcot. And I really want to hone in on that. When this person first shows up to your office, what does it look like? What are we going to do? And then what should I do, or where should I go from here? I'm going to kind of dig down the path a little bit on if this thing progresses, some of the treatment options we have. I'm also going to talk about some of the bigger reconstructive things, because if you do see some of these patients in your office who end up with frames on or have skin grafts or any of these bigger surgical procedures that can be undertaken, I don't want you to see a big pin. Maybe it looks a little wet, or is it infected? What do we do? Just to kind of see what options are available to you if you do see these patients in your office that have undergone reconstruction. I'm going to show you that first case, the one big case presentation I have. And then I also want to show you exactly where this thing is going, because I think Charcot is finally becoming one of the things that a lot of the companies are recognizing, seeing, and truly caring for. So this slide is probably preaching to the choir, but especially from our primary care world, our diabetic patient population is continuing to increase. And I think these first bullet point, as well as our third bullet point, are the ones that stand out to me the most. Now, an estimated 15% of people with diabetes experience a serious foot problem. I truthfully think that number is going up. And I really truthfully blame it on, the patients are just waiting more and essentially longer now. So when I'm seeing these patients in the wound care center, they've waited months and months and months until this wound has gotten pretty serious. And then now we're talking amputation instead of being able to do basic wound care, maybe getting them a wound vac, other wound care modalities to heal them up. So I think this 15% is going to be drastically higher here in the next few years. And I also think a lot of these, 20 million Americans with diabetes, and then nearly 1/3 of patients don't know they have it. I think that number has also been increasing, at least in my practice at the wound care center. We're getting a lot of patients, they get these wounds, they're like, oh, I didn't feel it. I showed up one day, my foot was bleeding after I got out of the shower. And then, we checked their HbA1c, we work them up, and bam, they've got diabetes. So I think these numbers alone are staggering, but the fact that they're waiting so long to get seen and really neglecting their care just because maybe they're scared to come into the ER, scared to come into the primary care office, these numbers are going to continue to, unfortunately, increase as we continue to go on. Now, the key to Charcot, one of the main keys, is there has to be a neuropathic component to this to develop the Charcot. And when we talk about diabetic neuropathy, approximately 60% of our diabetics will have some form of neuropathy. Now, in my personal clinic, I like to test a lot of different pathways on these patients. I test both proprioceptive, so I'm moving their foot up and down, I'm moving their big toe up and down, asking them, is your toe up, is your toe down, without having them look at it. I'm doing a Sims-Weinstein, so I'm seeing if they can feel that light touch sensation. And I'm also testing their vibratory sense, because I want to make sure if, am I missing a neuropathy or a neuropathic component because I don't want to? And then B, where is it really coming from? And I'll check all the way out to the toes, the midfoot, the ankle, and into the tibia, just to be super safe on these patients. And as we all know, and I know once again, preaching to the choir here, these diabetics with neuropathy, they tend to be worse in our patients who are smokers, people who are really getting a little bit older and that have a really hard time controlling their blood pressure or blood glucose. When we have that, I always call it a little bit of cerebral neuropathy as well, because sometimes it's just really hard to reach these people. So patient education is crucial to continue to talk to them, remind them. And I'll even bring out, I know I've got some frames behind me here. I'll bring out these big frames, let them hold it and say, hey, listen, if we don't get this under control, you continue to worsen, you could end up in something like this, or you could end up with a baloney amputation. And then we also talk about the mortality rate that comes along with that, unfortunately. Other things that used to be a big deal for Charcot neuroarthropathy were tertiary syphilis. So before diabetes was so darn prevalent, we would actually, most of our Charcot patients would come from our syphilis type patients, unfortunately. And so the key once again here is to notice that anything can truthfully, if it has a neuropathic component, it can develop into a Charcot neuroarthropathy. And so one of the keys is recognizing these, at-risk patients and say, they show up one day, they have tertiary syphilis seems ridiculous, but say they have tertiary syphilis, they come into the office and next thing they got this big red swollen leg, no wounds, had maybe there's really minor injury. And you really should start, just considering the possibility of a Charcot on this type of patient. When we talk about Charcot, the incidence here seems pretty slim. So, only 0.3 in 1,000 will develop the Charcot neuroarthropathy. Once again, I believe these numbers are just continuing to increase, at least in my patient population. And then this 5th to 6th decade, I have a ton of patients in my office that are a lot younger than this now. And so unfortunately, I do have a pretty sad patient who's in his mid-20s, his bilateral Charcot, so Charcot on both sides. He's suffered multiple heart attacks. He's on renal dialysis and end-stage renal on the kidney transplant list. And so these people are getting sicker and are developing Charcot, and we're trying to, stabilize these feet. And I think once again, recognition for these patients is key. And so when we start talking about how this happens, so when we have the neuropathic component, and then we want to know exactly, well, how does it develop in the Charcot? So once again, big key point here, decrease or loss of protective sensation. And I've seen it so much that, maybe it's just a toe that is neuropathic and it's maybe just the tips of the toes. And then they start to develop this really weird midfoot bone deformity, and it actually turns into a full-blown midfoot Charcot. What we see with that loss of protective sensation, you'll get essentially some repetitive microtrauma or a minor or major traumatic event. So if the patient shows up to your office, says, hey, listen, doc, I rolled my ankle or I stepped in a hole and felt really weird, and you look at their leg, it's massively swollen compared to the other side. Maybe it's a little red. At that point, I'm pretty suspicious of Charcot, to be brutally honest with you, and I'm getting them off that foot and really kind of honing in to make sure we're taking care of this. Typically what I'll see on this patient is, a ligamentous injury and then essentially this repetitive microtrauma. So they roll their ankle and then they just walk through it because they're like, well, it wasn't too bad, but doc, I woke up 2 days later and my foot's really, really, really swollen. So it's typically a combination of, these injury patterns that I'll see when they'll show up in my office and say, hey, this looks kind of weird. What should I do about it? Now, differentiating between Charcot and essentially all these other pathologies is also a big deal. And so I think that's where the big crux of this comes, especially in the primary care world, because it's CYA, you don't want to miss something. And so you get this big red swollen leg, you're thinking, okay, well, this could be a DVT, it could be cellulitis, maybe they got bone infection, a simple ankle sprain shouldn't do this, maybe they got gout. So having those differentials in your back of your mind is great, and always making sure you're ruling them out is also great. But on these at-risk high patients, anyone with that neuropathic component, I am heavily leaning Charcot at that point. Obviously, we're going to order our ultrasounds to rule out DVT. We're going to draw some labs, making sure nothing else weird's going on. And then truthfully, to differentiate between our Charcot and our infection, I really look at our history and clinical examination. I do draw some labs, and I think the big ones here, ESR and CRP for me. So in our infected type group, we usually see pretty high ESRs and CRPs, but when we have Charcot, typically they end up being a little bit on that kind of gray zone. Maybe your ESR is only 20, your CPR is under 5, and you're like, oh, this isn't really that high. maybe you order a CBC with diff, the white count's a little elevated, maybe not, maybe it's sitting around 10. That's when, again, my suspicions really peaked, because those values aren't, when you see these big swollen legs that are red, you'd expect the white count to be higher. If it was infected, you'd expect the CRP and ESR to be a little bit more elevated. So if you have that kind of gray zone area, that's when I start to say, okay, I'm kind of leaning away from infection more towards Charcot. Now, typically, you're going to order x-rays. These x-rays might be, once again, non-definitive. They might look like WW, where you have those really minimal changes. And so sometimes, like in that classic case I gave you, we'll go forward with the bone scan. Sometimes you'll order a white labeled blood cell scan just to be super safe. But the gold standard, if you want to diagnose differentiate between Charcot and infection, is truthfully getting that bone biopsy, which is pretty hard to do unless you send it to a foot and ankle specialist who's willing to essentially go in there and take a bone biopsy. And some of them might not even be willing to see it until a deformity has showed up, or maybe they've got a wound or something more serious is going on. But in my practice, if you call me on the phone and say, hey, Eric, listen, got a patient, really minimal trauma, ended up in the office and weird lab values, send them over. I'm going to take a look. I'm going to essentially be a bulldog about this and really be aggressive about treating these patients really conservatively, to try to stop the Charcot from progressing, essentially. When we start talking further about Charcot, if you send it to a foot and ankle specialist or an orthopod, we all like to classify things. For whatever reason, we classify them into all these different groups and categories to kind of be able to talk to each other and say, hey, this is going on. This is what the classification, here's where we're at, and this is what we're doing about it. So if you get a note back from me and you see any of these classification systems, that's just our way of describing the Charcot and what's going on. The biggest one, or the most common one that I see, or at least, if I get referred from an outside foot and ankle physician or a primary care physician, typically I'll get this Eichenholz classification system. Now it stages between 1 and 3, and you can see they're each named development, coalescence, and reconstruction. But there's been a big push in the community, and there's been a lot of research done to show there's truthfully a stage 0. And so that stage 0 is that initial onset. And that's where I'm going to really focus in on today, is that stage 0. And so when we talk about stage 0 Eichenholz, this is usually when the first time they show up to your office and they start, they have that weird subtle injury, and they come in and you see this significant swelling. And so I've seen these patients, I've got a picture here on the next slide, where you look at one leg and you're almost blown away by how swollen the other leg is. It's 3 or 4 plus pitting. It involves the entirety of the leg. So it's from the knee all the way down to the toes. And you're just like, oh my goodness, this is super swollen. And then sometimes they'll have redness and warmth, other times not. And once again, with these Charcot patients, if they have to have some form of neuropathy, pain's truly variable there. So some of these patients are no pain. They just come into you because, well, hey, it's swollen and that's not good. Or they're in extreme pain and they're like, what the heck's going on, doc? Other times they'll just come in with some basic complaints of difficulty wearing shoes, maybe some breakdown in the skin. Their skin might be just, having like a scab or a wear pattern to it. And truthfully, there's no deformity. So you look at this foot and it looks osseously stable. So the foot has its architecture there, and there's really truly no breakdown. And you're like, okay, that's pretty weird. And that's when that first patient, this is the patient that you're just, okay, let's get you off it. Let's see let's draw some labs. Let's see what's going on and kind of go from there. But here's that picture. And I think this, to me, it's not as swollen. Maybe I'd say a +2, but when I compare it to that other leg, I always am astounded when I look at that ankle joint and say, hey, this thing's pretty darn swollen. And you can see there's usually not that much redness. Maybe there's some warmth there. I know it says usually profound, but for me, sometimes there's warmth, sometimes there's not. And the erythema on this stage 0 is truthfully not present. Sometimes you'll have a decreased sensation, but sometimes it'll be only out to the toes. And then you check their vascular exams, perfectly normal. So this is that really basic first come into the office type patient. And this is the one I want to focus in on, just because this is that pre-Charcot, before anything goes super terrible. And if we stop it here, we can sometimes stop it from the deformity forming and continue to worsen. And so when we take our x-rays, this is that normal x-ray. And so I know I have a radiologist here, but when I look at this x-ray, maybe I have some widening between the first and second metatarsal there. I probably would have grabbed another foot x-ray to take a look at those two bones and say, okay, is that separation the same or is it wider? If it's wider, maybe I have a Liz Frank injury. So anyways, I'm getting them off it. But with the neuropathic patient, with the edema, maybe no warmth, maybe no redness, I'm getting them off it just to be safe, to make sure if this is a beginning of a Charcot, I do not want it to progress and worsen. And once again, these things can progress fast. And so when you see this, once again, we look at that first picture, the initial x-ray, once again, you have maybe some minimal widening there, maybe a touch of fragmentation in between that little space in between the first and second bones, but truthfully, it's not terrible. And you can see in 2 months, if I look at this x-ray now, we have bony overlap, we have fragmentation, we've got destruction of our bony architecture. Essentially, those metatarsal bones are almost on top of the midfoot bones. And now we have complete destruction of the normal architecture of the foot. If this patient would have gotten off his foot from that initial x-ray day one, didn't put any pressure down, pretended like you had a true Liz Frank injury, casted him, gotten him off it, maybe put him in a walking boot just to be super safe, this might not have developed this quickly or even at all. And so we could have stopped at that normal architecture and really been able to prevent this from worsening on to a full-blown Charcot breakdown. If we have this first Charcot, when you have that first initial concern, and you look at this and you say, okay, Eric said if it's swollen, if there's a minimal injury, what do I do about it? I am big on patient and family education. Like I said, I'll bring out those frames, I'll bring out brochures, I'll bring out pictures of baloney amputations and say, hey, listen, if you stop here, you get off your foot, you work with your primary care physician to get those blood glucose levels under control. We get you off the foot, make sure you're really strict about staying off the foot. I can keep you where you're at now, and it won't worsen to something where I put you in a frame or end up having to cut your leg off. So that initial treatment, truthfully, and I'll tend to cast them because I just don't trust patients to do what I say. Just because I've been burnt by too many diabetics who will say, yeah, doc, I'm gonna stay off it. I'm gonna get my blood glucose under control. And next thing I know, I go out to the front of our office and they're holding their crutches and just walking out like willy-nilly. They come back in 2 weeks later, and next thing you know, they've got a full-blown Charcot at that point. And I am pretty strict about their blood glucose control. I'm, looking at their last HbA1c. I'm usually getting in touch with the PCP to say, hey, how do we get this better in control? Here's what's going on. And then making sure that I'm offloading or taking off their foot. And so this picture here is pretty aggressive, but this is a cast I'll do for Charcot because I don't know what the swelling is going to do. So what I'll do is I'll get this big fluffy pad. And if you've ever seen one of my post-ops, I do it almost on everybody, even not my diabetics. But I'll essentially fluff this whole foot. And so essentially it's got this big protective barrier. And then I'll cast it on top of that. And then I'll actually cut the cast down the side. We call it bivalving. So it allows for some of that swelling as it essentially decreases or increases over time. We're allowing that to essentially protect itself a little bit more. And so they don't develop skin wounds. And we're allowing for that swelling. And then say we stop it from there, we stop all the Charcot from developing when worsening. If we're talking long-term treatment, if I can protect that bony architecture, typically what I'll do is I'll actually get these patients into a custom orthotic. And I've seen this pretty frequently. Some people only put them in the one side that was affected, always put them in both. So, put an insert in the right, insert in the left. Don't leave them with one that's not in there because you don't know if that extra bit of padding could protect that other foot from even developing this stage 0. If they have some deformity, if say we saw them a little bit late, they had a little bit of split in the first and second bones and the bones started to shift just a touch, that's when we start talking custom bracing and custom shoes. Some patients don't like the custom bracing and custom shoes, but for me, it's way better than developing, that big crow walking boot, which looks like a Franken-Munster boot, almost like a foot coffin, because a lot of patients don't tolerate that at all either. I will periodically monitor these patients almost like you're going to the dentist. So typically, say we resolve it, I'll have the patient come back on a monthly basis, and then I try to start stretching it out. So say they do great month 1, good. Maybe we'll stretch out to 2 months, 3 months, 6 months. And that's usually about as far as I'll let them get out, especially if they've had a Charcot essentially attack, because I want to make sure that we're continuing to have the patient and family education. We're always doing serial radiographs to make sure there's no acute changes. And I just want to make sure the patient knows, hey, listen, if you have the slightest flare, the slightest bit of swelling, you come in, because at that point, we want to take those x-rays. We want to stop this from progressing to something a lot more serious, where you end up with something essentially that could have been preventable at that time. Typically, I will not do a lot of surgical procedures on my Eichenholz zeros. So on my basic, the first attempt at the Charcot attack, if we have to. So say on that x-ray that had that split between the Lisfranc joint, if that Lisfranc ligament is hurt in any way, shape, or form, sometimes I'll go in there, repair the Lisfranc, or potentially do a joint arthrodesis in between there. Tendon lengthening is crucial on some of these patients. So say we get an Eichenholz zero, but they have a wound on the ball of their foot. Typically what I'll do is go in there and do an Achilles tendon lengthening, because what that does is actually decreases the pressure to the ball of the foot in the middle of the foot by about 42%. And then I can also get them to stay off it. So at the same time we're casting them, we're decreasing the pressure to the ball of their foot, really being able to kind of take care of some of those problematic areas, while also hopefully in the future preventing some of these future problems in the wound arena, or even the worsening in the Charcot. Combination procedures, so say it was in the middle of the foot and we do a joint destructive procedure like an arthrodesis, sometimes we'll go back in there and do a tendon lengthening as well, just to essentially decrease that pressure to the ball of the foot. But in my Eichenholz zeros, it is very rare when I have to go forward and do an amputation or anything more severe, but I always warn them of this, because say they go in and they worsen, I say, hey, listen, you go from a 0 to a 3, and next thing you know, we're talking amputation. So I always bring this up on my surgical options, because I kind of want to scare the patient a little bit, just so they'll essentially follow what we're saying. You don't want them to think this is no big deal, my foot x-ray is normal, and then next thing you know, they're developing a worsening Charcot attack. So as this worsens from a 0 to a 1, we call this the development stage. And again, I tried to bring that picture back up of that patient with the swelling. And this one, you can actually see a little bit of the redness. I don't know if it translates great, but what you're seeing here is you're seeing on the right side, we have pretty normal looking foot and ankle and toes. And then if we look on the left-hand side there, we actually have these sausage digits. So you're seeing a pretty significant amount of edema. And now we have that erythema component. So this is the other stage. I typically see these patients show up to either the primary office or sometimes into my office. At this point, there's usually some warmth to the leg. So when you touch the right side, it's a little cool. You touch the left side, it's a little warm. And this is where I get a lot of the warning bells from my primary care physicians. They're saying, hey, listen, there might be some infection here. This is looking more cellulitic. What do we do? Typically, I'll have them grab an x-ray, and then we'll see what the x-rays are doing. Now, here on this lateral view, so we're taking a view from the side of the foot, I'm looking here and I can see at the talus, so the joint between the talus and the calcaneus, so the heel bone and the bone that connects to the ankle joint, you can see some true breakdown here between those two bones, as well as a possible, we call it an osteogonum versus a potential fracture fragment. If I see this without a wound, because sometimes my radiology colleagues will read this as potential, osteomyelitis potentially, or they'll read it as a fracture. At this point, without any big trauma or any sort of open wound, I am getting them off this foot. I'm treating it like it's a fracture, but I'm discussing with them, hey, listen, this is a early Charcot breakdown. Let's treat it like a fracture. Let's get you off this thing, and let's really protect this. Altered function, when these patients are walking in, this is where you start to get the limp, even if they're not painful, just because the bone has actually fragmented and fractured at this point. And so it's shifting out of the normal anatomy and normal architecture into almost like a fracture pattern. So once again, when I see this stage 1, I'm truthfully getting them off of it. If it further progresses to almost an Eichenholz 2, this is where the bones start to essentially consolidate just a touch. So when we're ordering these serial radiographs on these patients, this is where we start to see those bones on these Charcot patients essentially start to reform a little bit. We'll get this thing called sclerosis, which almost looks like a darkened white line into the bone. And we'll see essentially some of these bigger fracture fragments are actually starting to osseously bridge together. And that just means they're starting to fuse or heal in. and some of that debris will actually be gone. So if we kind of compare those two x-rays between stage 1 and stage 2 here, you can actually see that fracture fragment on the back of the talus. So the thing on the complete left-hand side of the x-ray picture actually has some bridging together. So you're seeing some of that bone healing into the heel bone as well as into the talus. And we're seeing a lot of that debris that was almost in the subtalar joint starting to resorb at this point. And then some of those darker white lines, if you look at the anatomical neck, or I'm sorry, the neck of the calcaneus, we can see some of that white, darker white lines there. Finally, it'll just progress to stage 3. And when we get to stage 3, this is the stage of reconstruction. So this is when the Charcot is pretty much almost done. And so this is where we start to have a conversation of, okay, let's get you in some shoe gear. Let's get you in an orthotic. Maybe I have to put you in that foot coffin for a few weeks before I essentially put you into a orthotic device in both your shoes. But what we're usually seeing is that swelling's almost gone at this point. The residual deformity that's there is now permanent. So if they have a little bit of collapse of their foot or they have a bulge to one side, that's essentially a permanent deformity at that point. And then when we look at it radiographically, we can see that the darkening white lines are gone. Most of the bones have become remodeled or start to have an architecture back to them that looks somewhat normal minus the deformity that's present. And then we have this rounding of bones. So you can see some of these bones that were a little bit more defined have now more rounded surfaces. And that's what we know our kind of Charcot deformity that went from a stage 0 has finally calmed down to almost a stage 3. If we can stop it to even full-blown Charcot attack, sometimes we can continue to keep a normal x-ray, but if they continue to walk, continue to essentially break down those bony fragments, they'll continue to worsen through these stages. And then I'm watching them once again. I usually catch them at the 1 or 2 stage, and we're being very aggressive in getting these people off it at this point. When we talk about the neuropathy, the Charcot neuroarthropathy, confirmation of diagnosis is crucial, for my primary care colleagues. And this are my 5 bullet points. And this is kind of the way to go through it. If you're, okay, how do I go from step 1 to getting them off their foot? Correlation of history and clinical exam is huge. So I get a lot of people that call me and say, hey, listen, once again, I got this big red foot, concerned about infection. There's no real wound. What do we do? So, without the wound, maybe there's that minor injury. Maybe the patient was just walking on their foot a little bit more, or we're out, in sandals, not great shoe gear. They have neuropathy. This is where your suspicion should peak. It should say, okay, I've got a diabetic, I've got no wounds, and then I also have a neuropathic component. Those 3 red flags should trigger this could be a Charcot. Confident exclusion of differential diagnosis. So ordering your DVT ultrasound, making sure you're doing a venous ultrasound, maybe getting some lab work to rule out the infection, just to make sure we're ruling out some of those other complications that can come with other problems. And then ordering some conventional pedial radiographs. And if there is red as a normal x-ray, lab values are pretty benign, maybe kind of in that gray area, but you have this big red swollen leg, get them off it. At that point, it is just get them off the foot, because we can potentially stop it from worsening at that point. Usually at this 3 point, I try to tell you to send them over to me, because at this point, I'm going to either order some specialized tests or move down to the further white label blood cell scan. But I can typically pick up from stage 3 and kind of take over from that point and make sure we're really stopping this from developing into something much more serious. So if I could tell you 2 big bullet points to take home here, it is highest level of suspicion. If you have a patient that comes in, once again, I know I'm beating it, but swollen, minor injury, diabetic with neuropathy, get them off the foot. That should be the biggest red flags in your brain. If you see that, that's when you know I need to make sure I'm ruling out Charcot and stopping this thing from progressing. The other one is recognizing the at-risk patients. So I know I had that slide which showed some of the other things that can cause neuropathy. Make sure if neuropathy is in there and they have something weird like this big swollen leg going on, make sure you once again have that highest index of suspicion. The patient's not going to be in jeopardy by getting off their foot for a few weeks until you can get them in with a foot or ankle specialist. That's really not going to kill them. Make sure you just get them off of it. That is the key. Switching gears here a little bit. I know I kind of got a little over the top with the just basic things. When you get a patient, say we have a diabetic, went through a big Charcot reconstruction, I really want to show you where this is going now. And so say they show up to my office, they're past that stage 3, we've already have kind of a permanent deformity. This algorithm was the gold standard for Charcot neuroarthropathy for almost until 2018. And so as you can see here, as you work your way down this treatment algorithm, surgery is only mentioned one time, and it's only mentioned if you can actually correct, or I'm sorry, if you cannot accommodate the deformity. What we're seeing now is more, can we get this patient into a normal shoe? Can we take this patient with this deformity, even if it's not accommodatable, and get them into a normal shoe? So Dr. Armstrong was the one who kind of led this push on how to treat these diabetic Charcot neuroarthropathies and gave us that algorithm. But what we saw about 8 years later, Dr. Saltzman came out and was like, hey, listen, about 50% of these patients with Charcot are truthfully developing recurrent ulcerations about 50% of the time. And anytime we get a recurrent ulceration, what we're seeing is that that's putting that patient at risk, and that's putting risk for below knee amputation. And like I said earlier, if you have a below knee amputation or a major limb amputation, what we're seeing is the survivability of those patients is not high. And so Dr. Saltzman went on and kind of partnered with a doctor named Dr. Pinzer. Now, Dr. Pinzer is kind of the godfather of the new wave of Charcot. He's out of Loyola in Chicago. And his whole thing in 2018, so this is really recent, was that we need to have an excellent outcome for these patients. And an excellent outcome was defined as being able to take a shoe off the shelf, getting an insert from maybe a custom insert, and being able to get these diabetics into that, even if they have Charcot. Now, what that entailed was that more of these people were going on to surgical correction. That surgical correction, once again, was going for that excellent result. And this changed my practice completely. And so typically with the Charcot before 2018, a successful excellent result was that if the foot was flat. If the foot was flat, sometimes we could not get them in normal shoes. Sometimes we couldn't even get them in inserts in shoes. We actually had to put them in that Charcot restraint walker, which is that big black boot. And a lot of those patients didn't tolerate it. They'd walk all over their reconstruction, break it down with a bunch of hardware, and now the situations become even more complex. And so Dr. Pinzer went on and said, hey, listen, let's make this way better. We should shoot for a foot that has almost a normal arch or a somewhat normal arch that I can get into a New Balance shoe that the patient just takes off the shelf. And what he was able to produce were pretty significant results. And so this has changed the way most of our Charcot reconstructive surgeons think. It's no longer, I'm going to get you a flat foot and you're going to be perfect. It's, I need to get you an arch. I need to make your foot almost normal and essentially be able to get you into a regular shoe. So that's what most of our foot and ankle colleagues that do Charcot reconstruction more frequently are shooting for. And that's the goal. It should be all the time for these patients. When they go on to Charcot reconstruction, what I want to make you guys aware of are a lot of the treatment adjuncts. And so when I do these big Charcot surgeries and I put them in these frames and the hardware that sits on the outside of the body, and I put hardware inside the body, I tell all of them a pin track infection, a pin that is sticking out of your body is a guarantee. There is no way you're going to avoid it. When we see pin track infections, I try to kind of stage them and essentially grade them and say, okay, is it just some mild redness around the pin, or is it having pus draining out of the pin and we need to go and do something about it? So if you look at this picture, there's a lot going on. And so the middle pin is actually broken and there is a little bit of redness around there. And if that was my only issue, if I had maybe one broken pin, but I had 2 remaining, I'd probably be able to treat this patient with aggressive pin care, with maybe some iodine, maybe some chlorhexidine, and then an oral antibiotic. But if you look at the bottom pin, you can see there's a little pus pocket sitting around there. And this is when we actually have to take the patient back. And then you make these things super aggressive. This is actually one of my cases. If the pins become that infected and we're losing that many pins, you have to actually go back in and then make it a very, very rigid construct. What the pins are doing, what the frame is doing, is all the surgery was in the ankle. And so I'm trying to disperse the pressure away from the ankle to allow the bones to heal and essentially put those into the leg and take away the pressure and put it into the leg is what I'm trying to do. If those pins get sacrificed, that's when we have to make it even more rigid to allow these essentially patients to heal up pretty significantly. And you can see it went from something pretty basic to something a little bit more advanced, where we've got clamps and bars and pins coming out everywhere. And sometimes when you have these patients that don't take it as serious, if they get to this point, they're taking it serious at this point, because you're getting a lot more hardware. It looks like an erector set sitting on the front of your ankle, and it freaks them out. And so at this point, I'm like, hey, listen, we took it for granted. Let's not do it again. This is what we have. Let's kind of go from here. The other thing I guarantee my patients, wounds, 100%. Why that is because I'm moving and shifting skin in places that it probably hasn't been in a while. And when I get that foot from, maybe lopped on, walking on the side of it, to a perfectly neutral position, I'm stretching that skin envelope pretty significantly. Wounds are almost a guarantee, but I am super aggressive with this. So if I see a wound in my clinic, I am typically, taking it, doing it more of an advanced wound care modality. I'm not just putting a wet to dry on there and saying good luck. I'm usually doing a collagen-based dressing. I'm doing an A-cell powder, or I'm doing a skin substitute. I want to see a 50% reduction in my wound size and within 3 to 4 weeks, or I'm taking them on to do split thickness skin grafting. And this is particularly challenging in these patients that we have frames on. And what you can see in this picture, this is another one of my cases. Patient had a foot they were walking on the side of. I was able to get it nice and straight, but unfortunately they developed this big wound on essentially the side of their foot. Now, I'm not a big fan of taking skin from the other leg, because then I'm creating problems on the other side. I like to take it from the same side. So what we'll usually do here is, if I don't get that 50% reduction in the wound size, I'll actually take it and put a split thickness skin graft on there to really kind of progress this quickly. And with skin grafting, I want to see resolution of the wound within 10 to 14 days, so about 2 weeks. I'll push it sometimes up to 3 weeks before I'm taking them back. Now we're talking muscle flaps and a little bit more aggressive at that point. Why I wanted to bring this up is because some of my foot and ankle colleagues will only see these Charcot patients back maybe every other week, sometimes once a month. So they could end up in your office. And if they end up in your office, I don't want it to seem like a foreign material or a whole new world of language. This is something that is really manageable. And if you see it and you're like, hey, listen, they've got a wound, that's when you call the surgeon who did it, and they should be bringing them in that day and really assessing the situation. The other thing I want to make you aware of for our patients that we have these big reconstruction on are something called angiosomes. And so essentially what this is there's 3 main vessels that go down to the leg and the foot. We have our posterior tib, our perineal, and our anterior tib dorsalis pedis. Those vessels are the main blood supply here. So say you have a patient, we're going to ignore pin tracks. There's no pin track infection, but they have a wound. The surgeon hasn't seen them back. You do a chart check. You're like, oh, that's weird. There's no real blood vessel or arterial workup. At that point, a wound plus no arterial workup, arterial ultrasound, CTA, you should be checking these vessels. Reason being is, if for some reason one of these vessels shut down in the reconstruction, we need to make sure that blood vessel is well perfused again, so that this thing doesn't worsen and become catastrophic and end up in an amputation. So we're always assessing, at this point, if there's no blood flow studies, order them. It's pretty simple. They can do it, on an outpatient basis these days. There's plenty of different centers out there that offer same-day visits that can scan them. If they can't scan them, or they're too nervous to scan them with the big frame on there, CTA is always an option. And if I, for some reason, I typically don't miss this, but we're all human. If I don't order an arterial ultrasound on these patients prior to surgery, I get a wound, I'm assessing those vessels, I'm talking over with my vascular colleagues to really make sure that we're taking the best care and giving this patient the best possible outcome I can achieve. So my own personal case, and it was early in my career, so this is the first one I did, and this was in 2017, so I'm just going to stipulate a few things here. This was before Dr. Pinzard released that study, so in my brain, I was trying to get this patient a flat foot, is what I was trying to do. This was a super sweet lady, and she is still around walking today, so spoiler alert, but she was a 60-year-old lady, came to me from a outside care facility to my private clinic here in what my MA called a conformed cam boot. You can see her past medical history is pretty significant, especially with her breast cancer and metastasis to her bones. But good news, the last treatment or last radiation was in 2006. So we had some remission going on, which is great. This patient fell and then essentially showed up to my office looking like this. And when I got these x-rays early on in my career, I was like, oh my goodness, I cannot believe no one took her in, put a frame on, and kind of got her out, because essentially this was just a regular or a significant ankle fracture that could have been easily stabilized. But they just put her in a boot, told her it was going to be okay, and go ahead and walk on it. If you look at this x-ray, almost nothing is normal. The foot is all the way over to the side. The ankle is completely dislocated. And if we want to see a clinical picture of her foot, this is it. And so the top-down view of her foot, you can actually see the ankle sticking off to the side. That's how bad it was. The clinical picture of her foot, that little red area was actually the tibia sticking out of her ankle. And then if you look over to the essentially just a little bit more central, that kind of red scar, that was actually her tibial crest. And so the second toe should actually be in line with that tibial crest. And so that's how far her foot was off. They left her like this. And when I called the physician up in, it was actually in Wyoming, they were just essentially saying they were too nervous to touch her based off her past medical history and her comorbidities. And I was just a little appalled, because you just cannot leave anyone like this. So I took her back in that day, and I wanted to see if I could even get this foot to neutral. So I treated it like an open fracture, took it in. I actually was able to get her central. So this is a delta frame, so a little bit different. This is more of a trauma frame. So when we get these really bad fractures, and I know Dr. Rumley would be happy because I put one of those metatarsal pins in he loves. But what we see here is I was able to get this foot back into neutral. What I did here is, because I was treating this as both a Charcot and a trauma, was I actually opened her up and put an antibiotic spacer in here, because I didn't want there to be any bone infection if I was going to have to stick hardware in here. Unfortunately, her bone biopsy did come back positive, so we had to treat her with 6 weeks of IV antibiotics plus essentially the antibiotic spacer. And then I was pretty limited. So I talked to her. I said, hey, we can do a reconstruction, try to get you flat, but we're going to have to put an antibiotic essentially nail in there. I can no longer just put plates and screws and try to fix your ankle, or we can do an amputation. And she was adamant of trying to save this thing. And so I said, let's do it. So in 8 weeks, I took her back to surgery, and essentially I had to open up almost everything. And so during this case, I don't think North Suburban's ever seen anything like this, because I had probably about 20 people come into the room and look at it, and you could see completely through the foot, and it was just completely filleted open. But this was a case where I took a bone biopsy to make sure we were clear. I was able to kind of get a nail in there, but sadly, when I did this case, I had a little bit of a complication, because I did not have a physician assistant. I have a phenomenal one now, but I didn't have one at the time. And so I had a scrub tech helping me. And when you're putting these nails in on this really Charcot bone, it can be almost like butter. What happened was the person holding the leg turned it, and the nail and the ankle came completely out the side of the foot. And so at that point, I was very fortunate to have the training I did, because what we did at that point is we took out the big fibular fragment, which we already had taken out to do the procedure. We essentially ground that up and morselized it and put a bunch of bone cement to build her a new heel bone, essentially. And as you can see, we were able to get the kind of the rod and everything stable in there. I know my orthopedic colleagues looking at this will say my screws are too long in the proximal holes, but at that point, when I had a nail sticking out the side, I just wanted to make sure this patient was stable. So I was just happy with being able to get it in position. And then I put essentially a ton of screws down in the middle of the foot to give her that nice flat foot. And at the last day in 2018, when I saw her, this is right when Pinzer's article came out. And then when I was like, oh my goodness, I failed, because I gave her a flat foot and not something that she could, put it in a normal shoe in. I was almost disappointed, but she was ecstatic, because she was actually walking on both sides without any issues in one of those crow boots, so the Charcot restraint walkers. And she was doing just fine. And I just saw her back still walking, but she did unfortunately develop a Charcot on the other foot. And so now we're talking about reconstruction on that. And she's unfortunately going to hold off just for a little bit of time, because it's a pretty big undertaking. You're down for about 3 months. with something like this. So I was at my first thing in my career, I was actually pretty excited with this result. If I had to grade myself now, I'd look at this and say, I'd give it good, but it's nowhere close to excellent. And so reason being is I could not get her in a shoe. I didn't give her back a proper arch. I did give her the ability to walk. She didn't end up with a below knee amputation, but she was still in a Charcot boot. Now that was my training at the time. My practice has changed dramatically since then. So if I would do this again, I would try to reestablish her arch. I would probably put more bone graft in to even up that talus, the heel bone, and try to really get her into a much more anatomical position. Where is Charcot going? So the future of this is pretty neat. A few of our companies out there, Stryker, Wright Medical, Smith and Nephew, there's a ton of them out there which are developing these Charcot lines. And what we're seeing now is they're actually making 3D imprinted bones to kind of substitute for some of these other bones. And they're actually pretty neat. What they'll do is they'll take a CT scan of the side that's unaffected and give you all these different options of what their normal anatomy should be, because most of the feet are similar, but they have some differences in sizes. So we're actually able to 3D print these bones, find their pressure areas, and we're able actually to install these. The kind of other cool thing is, say you have a defect, they're actually able to essentially mimic that defect, put this 3D printed lattice in there, and kind of be able to reestablish almost a normal bony architecture. This is still pretty on the new end of things. What we've tried before is we've tried to put metal spacers in. We've tried to put taking a femur graft and putting it in the ankle to kind of reestablish some of those normal anatomy. And what we saw with that, unfortunately, was that it would fail. And the reason it would fail is we were taking their dead bone and putting it into an area that's not healthy, or we were putting these big metal cages, which the patients were just smushing through, unfortunately. So I think there's a lot of promise here. I think with the materials they're making out of and actually mimicking the patient's anatomy, I think we're going to be in a pretty good scenario to really get these patients darn near anatomic once we kind of get the ball rolling on some of these 3D printed implants. The other really cool thing, and this was started by our trauma colleagues, was they're actually able to do a computer kind of assisted frame to kind of help with some of the deformity. And how this started was with big tibial deformities. And so here, Dr. Hughes actually took essentially a Taylor spatial frame, plugged it into a computer program. They essentially found this area of rotation we call it cora, so where the big deformity's at. We're able to take these minimal bone cuts, put the frame on, get the area kind of almost darn near anatomic, and then they would throw a nail on top of that. And what we saw was almost complete normal anatomic resolution of their deformity, as well as almost 100% union. I think they had maybe one complication with a pin track infection. But once again, even in our trauma colleagues, if you're keeping this thing on there for a long period of time, you're guaranteeing that patient essentially a pin track infection. And how this is becoming a future modality is essentially we're now being able to do this for the foot and ankle. So we're able to plug in that Charcot deformity to a computer, and we're able to put this frame on, do minimal bone cuts and almost a minimally invasive surgery. And then in this frame, what you're seeing is these different tabs. And essentially those tabs give you an idea. The program says, okay, we'll twist twice on the blue tab and then twist in reverse once on the green tab. What that's doing is it's gradually correcting deformity over time. And what we're seeing there is we're actually decreasing some of those skin risks that come with these surgeries, as well as being able to do really minimal bone cuts to kind of get these deformities corrected. So that's where we're going. And I know I was a little in depth on some of the end stuff there, but I'd be happy to answer questions at this time.
So yeah, we'll go into some Q&A here, mainly with Dr. Kuhlman, or if you have any for me. We have a few in the chat. Anyone else that has some, feel free to shout them out after we finish these first few, or type them in the chat. And before he kind of gets to these questions, I guys want to remind you that Dr. Manub Sana, a radiologist at Health Images, is also with us tonight, and he can answer any questions as well. He's a board certified musculoskeletal radiologist and with Colorado Imaging Associates, and he has some specialization in sports medicine, orthopedic oncology, spine imaging, and has worked with multiple collegiate and professional teams, including the LA Lakers, Chicago Fire, and UCLA college athletes. So we had a question from Shannon earlier, Dr. Kuhlman, about, if a patient shows up to a clinic and they have a diagnosis of Charcot and they're just walking in normal shoes and they don't have orthotics or a walker boot or anything like that, would you put that on the patient they said that this patient specifically had been to a different orthopedic office and center, and that's where he got the diagnosis of Charcot. So would you put that on the other office, or would you put that on the patient? And my kind of addition to it, are there Charcot patients that you think do not require orthotics or you wouldn't recommend them for?
I almost any diabetic, even without Charcot, benefits from orthotics. Honestly, I mean, most people, even without diabetes, without Charcot, are beneficial. Orthotics are beneficial. To be brutally honest with you, we used to be able to stick them on everybody, and insurance started cutting those things, and unfortunately didn't let us do them as frequently. So with our Charcot patients in particular, I'm getting them in orthotics ASAP. I don't care what their excuses are. Some of them will come up with a million different reasons why they don't want to get them. Most of them are more worried about like ugly shoe gear and being able to fit them in there. Nowadays with orthotics, you can get them in anything. I mean, you can get them in high heels, you can get them in regular shoes. So to me, there's no excuse at that point, especially with a diabetic with a diagnosis of Charcot.
Perfect. Is there a specific type of orthotic that you recommend? I mean, you recommending custom orthotics, and you think there's a place for more basic things such as, Dr. Scholl's, Good Feet? There's some questions about what you would recommend as far as inserts.
I always prefer the custom orthotic, and specifically with my diabetics, most of the insurance companies will approve a multi-density insole. They'll proof them once to twice a year, so you can get a new pair about every 6 months. So I'll have them get the one pair. Sometimes the orthotic places will give them all 3 at once or all 2 at once. And what they do is they just kind of flop them in between shoes. They'll have them change them every 3 or 4 months, just to make sure they're not breaking them down that fast. And then getting them next year is totally fine. So custom molded multi-density inserts are the way to go for our diabetic patient populations, because they're doing 2 things. They're controlling the different pressure areas. And so diabetics and all of us, as we age, will end up having fat pad atrophy or having a deformity of our foot in some way, shape, or form. And so we're protecting that. We're floating and just taking away the pressure from that area. But we're also stabilizing the architecture that they have to ideally prevent it from worsening or breaking down if they do something silly.
So you said you can get this stuff in almost any shoe, but you had mentioned New Balance earlier. Do you recommend New Balance, or is there a brand, or does it matter?
So I really think nowadays with our shoe gear, having the patient understand what a good shoe is important. And so whenever I look at a shoe, I have them test 3 things. So I want them to be able to take a shoe. I think I got terrible shoes on right now, so I'll show you my shoe. I want to take a shoe, and if you can fold it in half, bad for your feet. If you can wring it like a towel, terrible for your feet. And then if you have a really small little heel cup, also not good for your feet. What I have them do is you only want to be able to bend at that metatarsal. So you don't want them to bend a little bit here, and you only want them to be able to wiggle a little bit side to side. So I have them check all the shoes, just because essentially shoes change yearly. And so they make them out of different materials. They make the uppers and lowers, the soles, all of those things change. And so whenever I recommend a brand of shoe, I say, hey, listen, Brooks might have been the way I went. Maybe it's not for your feet, but if you have a brand in particular that you like, most of them have a shoe that's stable and will work for your foot. And those are the 3 things you check for.
We have another question here about diabetic patients and what their income status is and their insurance status, Medicaid, Medicare, and what offices or what insurances will pay for these types of inserts and these types of treatments and things like that. What is your experience with that?
So typically our diabetics are most often covered. Now, usually they need to have some qualifying kind of diagnoses that go with it. So diabetes with neuropathy, sometimes the insurance won't cover, but if you add a deformity like a hammer toe, a bunion, arthritis, if you have sort of venous disease, so if they have peripheral vascular disease or arterial disease, you can add those kind of qualifying factors in there. And typically, if you have diabetes with neuropathy and a diagnosis of like a hammer toe, it's 100% covered.
Can you recommend, like, if we're not talking about diabetics and Charcot, there's some questions coming up about just standard inserts for shoes, whether that's Dr. Scholl's Good Feet, whatever. I know it has to do, I mean, you need an evaluation of the foot, and some of these places will actually do that. Some of these insert places will do that for patients, whether they have pes planus or a normal foot and they just have foot pain and they, you know, probably should be stretching their calves more. Or do you have just some recommendations about standard over-the-counter inserts and those kind of things?
So I always worry about Dr. Scholl's inserts in that machine they have you step on, because if you step on it 4 different times, it could recommend 4 different inserts. It just depends on kind of the pressure you put on that pad at that time. The Good Feet store has some good qualities. I have a hard time with them just because they claim to have these custom orthotics. And then when I see them and evaluate them, they look like an off the counter, kind of maybe a little molded to the foot orthotic, and they end up charging an astronomical fee where, you know, you do a true custom orthotic with me. You know, I think ours are $450 versus theirs are like $2,000 for 1 pair. And that just seems pretty astronomical for something that's off the shelf. If I'm looking at an off the shelf orthotic, just something that you could buy in the store, if I take the orthotic and you press the arch down and you can do it with just 1 finger, not good enough for your foot. You want something structural. So you want essentially something that's going to hold the arch up a little bit. You don't want it to be too aggressive or too low, but if you can press it down, that's not going to support your foot good enough. And same thing with the shoes, that big heel cup. If you have that contour to the heel, you want something called a deep heel cup to help control the back of the foot so it doesn't wiggle or shake too much. So I look to make sure that it has a little bit of depth. If it's just flat across and then like a little arch support, I don't think that's good enough. The last little thing I'll look for is I'll take the orthotic and I'll set it down on a table and I'll try to push it side to side. If it stays nice and solid, good. If it rocks too much, not good.
Thank you. Thank you. Dr. Sana, do you have anything to add about some of these imaging studies or things to look out for primary care patients, or any of the orthopedics that are in here that they may get an MRI for foot pain or x-rays and may see something? I mean, what should we be looking out for?
Yeah, that's a great question. First of all, that was a great talk, Dr. Kuhlman. I think you hit a lot of the major points. As far as the imaging piece of it goes, you know, I think one thing you mentioned earlier was that about 15% of diabetics come in with, you know, a Charcot joint, or sorry, 15% come in with severe foot complications. According to our literature, I mean, I think it's 15% with a Charcot joint, and then another massive percentage with diabetic foot infections. And, you know, just given how prevalent, you know, diabetes is, I think it's definitely something to highlight and be on everyone's radar. Charcot joint, you know, any sort of diabetic foot complication. As far as the imaging piece of it, you know, I think you kind of hit on all the modalities there. Definitely x-ray, you know, start with that. We can get a good sense of what's going on. You know, as far as what I look for on those, you can typically make the diagnosis of a Charcot joint by x-ray, given that it's past, you know, kind of stage 0 or stage 1. I mean, those early stages, it's like you were showing there, those images are near normal, if not completely normal. And so I would say get the x-ray. If you're going to get a foot x-ray and you're concerned about a Charcot joint, get a weight bearing x-ray so that I can really take a look at that Lisfranc and see if there's any sort of diastasis at all. And then after that, if any more advanced imaging is needed, you know, I I really love it whenever patients go see a specialist before any imaging. Otherwise, sometimes it's a little bit of a shot in the dark. Sometimes we see things on imaging that really have no clinical bearing whatsoever. You know, everybody's got a little wear and tear. They have a little bit of this, a little bit of that. But if it's coming from you, it definitely, you know, pricks up my ears, you know, and my eyes, and I just kind of take a good look at it. So I would move next to MRI. You know, do an MRI of the foot. You can do a non-con MR and we'll see pretty much everything. I think technically the gold standard is a with and without, but I feel like that may be a little overkill. You know, so just a good mid-foot protocol MRI. If you just write non-contrast MRI of the foot and, you know, you put in their Charcot joint, or the tech should run the correct protocol. I think we'll get our answer there. As far as bone scan and kind of the Indian 111 stuff, you know, the nuclear medicine, it's definitely out there and you can order it. I think, you know, at this point, MRIs just become so good that those scans they're in the textbooks. We see them from time to time, but you know, they can be non-specific. And even with MRI, there's just a lot of imaging overlap between an infected foot, an osteomyelitis, or a Charcot joint. It can be really tough to tell. But those nuclear medicine scans are even more tough sometimes. I mean, for a bone scan, for example, it's going to be hot on all three phases. For osteomyelitis, it's going to be hot on all three phases. For Charcot joint, which one is it? Kind of hard to tell. So yeah, I would say just a really good MRI of the foot. And then obviously your clinical input, I think, has a lot more bearing. You know, by the time they get to me, you know, it's the findings are typically a lot more obvious than if hopefully we can get them to you a little sooner, where it's just a little bit of sensory loss, proprioception, you know, some redness, some swelling. I mean, at the end of the day, these are just guys who can't, or people who can't feel their feet, right? I mean, diabetics just have chronic microvascular ischemia, which hits those microvascular nerves, and they just lose a lot more of those clinical signs earlier than when I can see it on imaging. So yeah, those are kind of my big takeaways from at least the radiology perspective.
Let me pick your brains as I have you here for a second. So there's a big debate at this last meeting I went to about CT scan. And so there's a big push from a few of the East Coast guys that they want to have a weight-bearing CT prior to their Charcot recon. And I think I can glean the same information from a regular CT. Maybe we have a 3D recon there. Are you seeing any of that out of anybody doing a bunch of recon?
So I would say in general, you know, CT is going to help us see. There's like
I'm saying more for like a pre-surgical. So this, we already know we're going,
sure.
we're doing reconstruction. We're
Sure,
going, we're full bowl at this point.
You know, in my mind, it doesn't really make sense unless you want to see the bony anatomy. I think with a good T1 sequence, you get excellent bony anatomy. The other thing about the MRI is that, right, the reason that I think they're doing it weight-bearing CT is because they want to see if there's any sort of diastasis or widening of the joint. And the joint's not going to widen if the ligaments are intact. And I can see all the ligaments on MRI. So why not just use a primary finding of ligament disruption, which I can see on MRI, rather than a secondary finding of joint widening on CT? So I just assumed that the ligament's disrupted. You know, I mean, there's maybe a little crossover between ligament laxity or not, but I don't think I know enough to know how that would change your operative approach.
Okay.
So,
and since you brought it up, I do want to know, have you seen this in practice? Has it just been with your diabetics, you're getting these MRIs on these just really blown up feet? Are you getting a lot more worsening of deformity, worsening of infection, worsening of wounds in your practice now than you were before?
Yeah, you know, I would say that you know, the biggest complication from a diabetic foot patient, it's osteomyelitis. I see that all day, every day. And then we get these Charcot patients thrown in the mix, and there's quite a bit of crossover. Sometimes it can be hard to tell. The biggest, I guess, point of contention within radiology as far as this topic is it infected or is it not? Because we see a ton of osteo, and these patients are set up for it. We see a ton of Charcot joint. These patients are good set up for it. And there's a lot of crossover in the imaging findings. And, you know, I personally, you know, I hate to hedge on these reports. I like to give you an answer, and, you know, if I'm wrong, I'm wrong. But at the end of the day, sometimes with these patients, you know, it can be really hard to tell. And the fact that you can actually do a bone biopsy and that you're not scared to do a bone biopsy is massive. You know, a lot of people are like, oh, I don't know, there's just a bunch of edema. There's a bunch of, you know, like bone marrow edema, soft tissue edema. Am I going to introduce some bacteria into the bone in an uninfected patient? And, you know, maybe they didn't have osteo before, but I'm going to give them osteo. And it's like, well, if you pick your track properly, if you kind of know what you're going for, I think it's helpful. And at the end of the day, one of my attendings would always tell me tissue is the issue. So, you know, the biopsy is not going to lie. It's going to tell you whether that bone's infected or not.
Thank you.
Yeah.
We had a question, Dr. Kuhlman, about these 3D printed bones and these cages and things that are coming out with, you know, new technologies, CT scans, MRIs, where we're able to kind of reconstruct some of this stuff, which is really cool. But maybe you can explain kind of how long these last, what's their, do they have absorption, or they kind of, does bone ingrow to them from what you are seeing in the marketplace? So do you have any information about that?
So with these big 3D printed implants, what their goal is to actually get that bony ingrowth. Now, unfortunately, there's not a ton of long-term studies. I think it's been around for about 5 years. So we don't have a lot of great clinical data about what it's doing in the long term. I've seen some pretty successful things coming out of the orthopedic literature just in general for Charcot reconstruction with the 3D printed implants. We always worry. And so this is another big thing we argued about at the meeting, was if I put this big 3D printed implant thing and it fails, and then I just crush through another bone because I've got this weighted implant in there, am I then dooming that person? And so what we saw with the metal cages that went in, it would actually subside into the heel bone, and then it would blow through the heel bone, and then we now had no heel bone. So we're still worried about that with the 3D printed implants. I think they're mechanically a little bit more forgiving than the metal, but I don't have any long-term data yet.
Don't put anything in that you can't take out.
Exactly.
That's my experience. You get too much bony ingrowth and it gets infected, you're in big trouble.
You're in big trouble.
Any other questions? Is that shirt pink or purple, Dr. Kuhlman?
It's more a mod.
Mod? Okay.
You couldn't even dress up for it. You had to wear your scrubs today, huh?
Well, I'm still on call, so,
okay.
You know, yeah.
Okay.
Taking care of ankle fractures and stuff like that.
I'll put the total ankles in them later.
I have a question as a primary care doc.
Yeah.
Sure.
Do you guys see much of any reversal of this damage if the blood sugar gets in excellent control? Or is it pretty much they've slipped down the slope?
I think at a stage 0, so when you have those minimal findings, maybe they weren't really respecting their body and kind of just going crazy with whatever they're eating and drinking. At that point, yes. If it gets into the full-blown attack and you have to go through a stage 1, stage 2, stage 3, once that deformity is present, it's irreversible unless you go in and correct it.
Okay.
I'll just chime in. I mean, in my mind, the whole pathophys of this process is they can't feel their feet. If you or I, you know, stress our foot or bang it up against something and it hurts, we're going to lay off of it. These patients, they can't feel it. So they're going to keep walking on a foot that's already hurt, and then it just gets worse and worse, and it snowballs. So,
Right.
you know, I think if you can get their diabetes under control and they can start feeling their feet again, yeah, sure. But, you know, it's like Dr. Kuhlman said, it's going to be at those early stages for sure.
Dr. Sana, can you comment on, this is going to go a little bit away from you, Dr. Coleman. I know that you can do more than just the foot and the ankle, but Charcot is not just the foot and ankle. So everybody understands that. That can be knee, hip, shoulder, elbow, even in the hand. Can you comment on some other joints
Yeah, sure. So we definitely see it most often in the foot, because diabetes is the main driver of that. There's a lot of other reasons to have a Charcot joint. So a Charcot joint is, again, it's just a joint that you cannot feel that you injured. So you keep using it, and it keeps, you know, and you keep getting these tiny little microfractures, and you get the fragmentation and you get the synovitis, and it's this massive snowball effect to where you get a completely disorganized joint. So diabetes in the foot, right? Because people get peripheral neuropathy. The second most common place I see it is in the spine. That's also typically from diabetes, and it's people will have like a little compression fracture and they just can't feel it. So they just keep doing whatever they're doing instead of laying off of it. And then you get the fragmentation. Ankle diabetes, you know, shoulder is another big place for a Charcot joint, but that's actually because you have a syrinx in your cervical spinal cord. So you have this little fluid collection that builds up in the central aspect of your spinal cord. You lose peripheral sensation in your arms because your arms are innervated by your cervical cord. And so you injure your shoulder and you just can't feel it. There's also even, you know, the patients who just have pain insensitivity or indifference, and they can just use they can just overuse a joint, and they're, you know, I guess they just don't care. They're like, it hurts, no big deal, and they just keep using it. Those people, I've never met one, but it's in the textbooks, and it's super weird. But again, I think it points to the fact that, you know, at the end of the day, they can't feel the damage that they're doing to their joints, so they just continue to use them. And I think the other most common place is the wrist too. Also, typically diabetes, but man, I can't even remember the last time I saw a diabetic or a Charcot wrist. Foot and ankle.
Seen one post injection, like where they do a steroid injection, blast the joint, and next thing you know, it Charcots.
You know, so I have not seen one from just like a therapeutic, like steroid and like lidocaine or a protein injection. There's a lot of people who have pain pumps, or who have, you can get something called massive chondrolysis. It's, you know, it's theoretically from injections, you know, a pain injection, a steroid, but typically those people are the people who get massive, rapid, you know, osteolysis. It's going to be some weird thing like Gorham's vanishing bone disease, or it's going to be just they have a continuous drip in there, and then it incites some inflammatory reaction. Their body's like, what's this weird stuff in my joint? I better release all these inflammatory cytokines, and then it just goes downhill. So yeah, you can see rapid, massive osteolysis in, you know, other joints. It can be injection related, but typically they have a chronic indwelling, you know, pain pump.
Okay.
To your comment there, Dr. Sana, I actually have had one patient that like literally had no pain response. I did a rotator cuff repair on a guy, it's probably a year ago, and he never took one pain pill because he said it didn't hurt at all. And that is totally abnormal. And the guy never had any pain, even through therapy and stuff like that. And I'm just telling you, it wasn't technique. There's something wrong with him. We're right. I mean, whatever you want to feel like, but you know. Well, Dr. Kuhlman, I don't know that there's any other questions that are popping up on my chat. Do you have any comments about claiming CME?
Got it right there. Bam. That's your code for claiming some CME. I'll leave it up there for a few minutes. Thank you all for coming. I really appreciate it. And everyone's input, Dr. Great.
I think our marketing specialist here, Karen, is going to probably send some stuff on claiming this CME after tonight's lecture. You can look here at this up on the screen as well. We want to thank everybody for joining us tonight and just come in and joining us through these CME events and these lecture series. It's kind of fun to do as a group here and getting everybody together on Zoom. Hopefully when COVID and everything passes, maybe we can do it all together in person. We want to thank our co-sponsor Health Images as well. They've been great partners to work with. They do great imaging and have great radiologists that we work with very closely. As far as the rest of 2021, my face would be one to look forward to, maybe or maybe not. I'm doing a total hip replacement talk next month, or actually, sorry, in November, on Wednesday, November 10th. So mark your calendars if you want to hear some more about total hip replacement, hip osteoarthritis, and the anterior approach to total hip. It's a pretty interesting and new approach. Patients are doing excellent from that. And we'll send out some electronic eval invitations to that. And then in 2022, we got kind of a whole new series coming for more CME, because everyone always needs that. We got 6 new lectures coming. So if you have suggested topics or anything like that, you want to shoot them over to Karen Johnson at Johnson K at Center for Spine and Orthopedics.com. We are happy to take suggestions on topics, because we got at least somebody in this practice that can talk about it. Or maybe we can rope in Dr. Sana again. So appreciate you joining us as well, brother. Thanks again for joining us tonight. Thank you, Jenna Gorgas and Adelaide from Health Images for co-sponsoring this series, and everything for joining us, and Dr. Kuhlman for your expertise, and maybe trim that beard.
How dare you?
Good night, everybody. Thank you.
Thanks, everybody.